Assalamu alaikum wa rahmatullahi wa barakatuh, everybody. I hope everyone's doing well today. Um, so today's talk is related to oral cancer by Dr. Zahra Saeed. So as general dentists, we are generally the people that will see patients with oral cancer first. We're highly likely to detect these things. And so it's important as dentists to be able to screen for this and know what signs to look for and know what appropriate steps to take afterwards. So inshallah, today we'll be learning about the signs of oral cancer, the warning signs, patient symptoms, and how they present in clinic, and then learn further about the steps to take in managing these patients. So inshallah, in a few moments, Dr. Zara Saeed will start her talk.
Are you happy for me to continue, Zayan? Thank you for the introduction.
Yeah, yeah.
First of all, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and welcome to the talk, and thank you for joining us today. So my talk is about potentially malignant oral lesions that you might see in primary care as general dentists, and how you might recognize the high versus low risk lesions and how you might manage these. So first of all, I'd like to show my appreciation to Dean for setting up this lecture and for linking me to you all, and Saqib, who liaised to help me in this talk. Also want to thank Ustad Fariha and Razia Jah, who gave me an insight into what dentistry and oral medicine is like within Afghanistan presently, and also my team and trainers who have helped me in the past. So as an introduction, I'm an oral medicine consultant. Oral medicine is a small dental specialty that works to look at oral health care of patients with medically related disorders of the maxillofacial region. Okay, so head and neck oddities that may not require surgery. As part of this role, I see patients with potentially malignant diseases in the mouth and in the head and neck region on a daily basis, and we have specialist higher risk patient clinics that we see and manage in conjunction with our OMFS teams and decide whether they need invasive treatment or not, and at what stage. We also support these patients who have these conditions and offer multidisciplinary team approach and meetings to plan all their treatment if they do unfortunately go on to convert into having a mouth cancer. So what I'm thinking and hoping that you'll take away from this talk today is how to recognize those lesions with higher risk of becoming oral cancer and the different types of cancers that you might see presenting in the mouth and the head and neck region. I want you to be able to note that prevention is better than cure, and that prevention is going to be provided by you in the primary care setting more than any of us in the secondary care setting, depending on what regimes are in place in that region. We want to provide an update onto current research that's going on into diagnosing such conditions, and also just to make a small link into what the challenges might be in Afghanistan into managing these conditions and the challenges that you may face. So the first thing is recognizing those lesions at risk, okay? So the best way to do that is to risk assess any patient that comes to the door for any lesions that might cause a problem to them. So that may be cancer, may not be cancer, but is a risk to them. And it's our duty, according to the Hippocratic Oath, to keep our patients safe and to do no harm. But when you're risk assessing anything, including patients, the process to do that is to collect information, i.e. take our histories, record and process that information, and come up with an action plan on how to manage that, and then act on that information and in those actions deliver the care that the patient needs as an individual to achieve the outcomes, to reduce the negative risk and impact on that patient as much as reasonably possible. Okay, so we're thinking whenever we're asking any questions, whenever we're looking at a patient, we're trying to get clues and to see whether this patient is at risk or not. Okay. So we want to start this with our initial assessment, and that's with our history, including the patient's demographics. For example, the age, gender, and occupation and race of the patient may give you more likelihood of one pathology over another. We want to know what the patient is complaining of, i.e., have they noticed the swelling? Have they noticed a patch themselves? Is there any pain, for example, neuropathic burning pain related to the nerves, or altered sensation, or bleeding, which may make it more risky for a more concerning high-risk lesion? We want the history of that complaint to know, is this a short-term symptom, or is this a long-term symptom, or is it getting worse? Anything that's going to increase in your mind the risk for this patient and help identify the cause of their problem. You want to know that the patient is going to be safe with any management that you may consider, and whether there's anything in the patient's medical history that might increase the likelihood of a high-risk lesion coming. So you want to know their past medical history. You want to know how well they are at the time. You want to know if they've had any previous diagnosis, either of cancer or oral cancer specifically, or other related conditions. And you want to know if they've had any therapy or any treatments in the past for this. You want to know what medication they're on, if they've got any allergies, anything that might make managing this patient more difficult or higher risk. You also want to be looking for risk factors that increase the risk of oral cancer specifically, and that might come about when you take your social history, including tobacco use. And in Afghanistan, I've been told that as well as smoking, Niswar is probably the main risk factor in terms of chewing tobacco specifically, that might increase the risk of oral cancers that they're seeing in secondary care. Obviously, there's other known risk factors, which we'll go through in detail as well. When you're examining the patient, first of all, that starts as soon as the patient comes into the room. You're examining to see if they're well in your general examination, whether you feel that the patient is underweight, whether they are a frail patient, problems with mobility, whether there's any obvious asymmetry or pathology as they walk in, and see about the capacity of the patient. Is this someone who will be able to understand any diagnosis you may give them and work with you to try and resolve the issue? Yeah. Do they have learning difficulties, for example? And then you want to go on to do your specific examination after you've taken your history. Remember, 80% of diagnosis comes from the history and 20% from the examination. So you start with your extraoral examination and then move on to your intraoral examination. And specifically when you're looking for high-risk lesions, you want to see if there's any spread, because if there's a spread of a lesion that you note within the mouth, then it's more likely to be cancer or a part of a systemic condition than something just within the mouth. So you want to do your lymph node examination, starting from your submental nodes and moving back up the neck to your preauricular, postauricular, and down to your anterior cervical chain, above the shoulders and posterior cervical chain, and end at your occipital lymph nodes. So that is part of your examination that you want to do. If the patient complained of any altered sensation or burning pain, you may also want to do a cranial nerve examination of the region that they have their complaint in, just to see whether there is any chance of spread to the local structures, such as blood vessels, which might cause some bleeding or bruising that you might notice. And if there is any altered sensation or burning to the nerves around the region as well. And that can give you an idea of how advanced or aggressive a lesion can be. Then once you're happy that you've collected all the information from that region, you then move on to your intraoral examination. And you need to look at every part of the mucosa of the lips, the surrounding skin, and inside the mouth. Okay, so you need to do this in a structured, systematic way, and something that you do every time a patient is examined. So you can start with the lips, move into the labial mucosae, onto the gingiva, in the upper and lower arches, the teeth, then the soft tissues of the hard and soft palate, the oropharynx, the tongue, and in all the surfaces, and the floor of the mouth and fauces region. So as far as physically visible, you've inspected all the regions, you've palpated any lesions that you noted, and in general medicine, they would ask you to possibly auscultate if possible, but there isn't really anything you would auscultate within the mouth. And percuss. So percuss you can do for fluid-filled lesions or cystic lesions, which you may find, but it doesn't give you too much information. So the main focus is on inspection and palpation. So touch, looking and feeling your way around the mouth for any signs of asymmetry or pathology or lesions. Okay, so what things in the history and examination will give us our red flags or concerning signs that this, whatever we're seeing, whatever the patient's complaining about, may be a higher risk for oral cancer. So from the history, if they've had a previous oral cancer, they are much more likely to have another cancer. Yeah. Other risk factors are if they use alcohol, the more frequently and the higher volume they use alcohol, the higher likelihood there is of a oral cancer. Any tobacco use, whether it's chewing, such as Niswar, which is, I'm told in Afghanistan is a common practice, smoking, or snus is, you can get tea bags of tobacco use. Betelquid, which is the areca nut, which is made into a paste, and in many subcontinental areas within the India and Pakistan and Bangladesh, is one of the high risk factors for oral cancer and something called oral submucous fibrosis. There's lots of evidence to say the same as cervical cancer, you can get HPV-16 and HR-HPV viral infections that can long-term increase your risk of oral cancer as well as cervical cancer, depending on the site they use. So if they know that they've had that anywhere in the body before, then they may be at higher risk of the lesion that you see in the mouth being a cancer or potentially cancerous. If there's any sun damage or long-term exposure, so if they've worked outside in fields in hot climates, higher up, closer to the sun, a lesion, for example, on the lips will be more likely to have the risk of becoming a cancer. There is very low evidence for the rest, but they could be anecdotal. But people who neglect themselves and have chemically processed meats, poor oral hygiene, and chronic mechanical irritation, some studies have shown that there is a possible link to this. However, this could be coincidental with self-neglect rather than a direct cause. Okay. From your examination, the lesion is more likely to be higher risk for cancer if the color is more red, there's any ulceration, the outside of the lesion is irregular rather than regular, so in an odd shape. When you feel the lesion, it feels hard, and in other cases, when it's more advanced, it feels like it breaks away easily and bleeds easily when you touch it. Okay. If the lesion is swollen, i.e. away from the mucosa, it's higher than the mucosa around it, it's more likely to be of concern than if it is flat. Okay. And if you have noted on your examination of the neck any lymphadenopathy, especially if this is non-tender, non-mobile, and firm, then more likely that this is a cancer than anything else. Okay. So bleeding, it depends on if this is an acute bleed or if it's chronically bleeding ulcer without infection, then it's more likely to be concerning for a cancer. So oral potentially malignant conditions, or OPMD, as the acronym is used in research worldwide, are very many. So any white patch or leukoplakia will have a higher risk than normal mucosa of becoming a cancer. This is especially true of a specific type of white patch, which is thicker, called proliferative verrucous leukoplakia, and between 60 and 90% of these lesions can turn into a cancer. We said anything that's more red, i.e. erythroplakia or erythroleukoplakia, will have higher risk of becoming cancer at some point, because likelihood is that the skin is either thinner or they've had chronic inflammation, and increased cell turnover, increased risk of mutations, increased risk of the screening system for these lagging and causing a cancer. We know certain inflammatory conditions have an increased risk of oral cancer. So oral lichen planus, very common. Up to 1 in 10 people worldwide will get this at any point in their life, and this can be children versus adults. And 1% of these patients will go on to have a cancer over 10 years of having the lesion. Oral lupus erythematosus, or discoid lupus erythematosus of the mouth in particular, has a similar risk as oral lichen planus. And then lesions of the lips, such as actinic keratosis and oral submucous fibrosis from betel quid use or barn use over time, are known to have increased lesions. Less common lesions that have higher risk of cancers are burns from the patients with reverse smoking habits, i.e. where they put the lit end of the cigarette into their mouth, and congenital conditions such as dyskeratosis congenita, and graft versus host disease after hematological bone marrow transplant. Those patients have a reduced immune system and can get lichenoid type reactions to the chronic graft versus host disease, and those have a higher potential than even lichen planus of becoming malignant over time. So a white leukoplakia can look like this, or it can be the proliferative form, which is thickened and raised over the mucosa, as you see here and here. Red lesions such as this, which when you look at it, you can't tell if this is an ulcer or just a red patch, but if you feel with your finger on palpation, you'll find that there is mucosa intact. If it's just a red lesion or an atrophic lesion, or if there isn't a mucosa attached, then we call this ulceration, and both will have a higher risk of becoming a malignancy or being a malignancy at this stage. In terms of photos, anything that has reflection over a lesion, then the mucosa is likely to be intact because the saliva is being caught and pooled in those regions. So we know that in this lesion, the mucosa is intact and this is a red patch rather than an ulceration. So this is lichen planus, but both graft versus host disease and lichenoid reactions, which are higher risk for cancer, will have a risk of becoming cancer. And this is PON-related oral submucous fibrosis. And you can see they've got leukoplakias and thinning. And when you touch this, this will be very hard. However, rather than being focal in a single area, which a cancer would be, this will be throughout the opening of the mouth, the buccal mucosa, soft palate, labial mucosae, and floor of mouth. And within this, you want to see if there's any red or thickened white changes. And in this patient, you can see on the palate, rather than the buccal mucosa, there is some thickened white patch, and it would be that area that would be the highest concern for becoming a cancer in the future. So is it easy or is it hard to distinguish a cancer just by looking at it? So if you think of all these lesions, I want you to think about which one of these would you think would be the highest risk of an oral cancer? Because in reality, only one of these lesions is a cancer. Okay, so think about it in your mind. Choose which of the 6 is, yeah. And I can tell you that we said that the more ulcerated a lesion is, the more red it is, the more likely it is to be a cancer. However, the little gingival white patch is the only cancer in this lesion. So really, it's very, very hard to distinguish any lesion from being a cancer or not, or being higher risk for a cancer. So the other lesions here are recurrent oral atlas ulceration in the first picture. As we said, SCC squamous cell carcinoma in the second picture. The third picture is oral tuberculosis, which you may also come across depending on your vaccination programs in Afghanistan. The fourth picture is actually oral syphilis as the primary infection. This is a chemical burn in the next picture, and the last picture in the bottom right-hand side of your screen is oral Crohn's disease. So it's very hard just by looking at a lesion without having a lot of experience at looking at soft tissue diseases to know whether something is going to be higher risk for a cancer or not. Okay, if I was looking at these patients, there's only probably 3 out of the 6 that I would biopsy. Okay, so what are the different types of cancers that you would see in the mouth, and how would you recognize them? Okay, so as I said, it's very hard to distinguish, but the most common oral cancer that you will see by far in the mouth is squamous cell carcinoma. So this is an oral cancer that affects about 11.6, that's supposed to be 100,000 people in the population worldwide, and it still has a poor prognosis even with the advances over the years. So worldwide, I mean, in developed countries, the best prognosis we have is 69.5%. It may be worse in those patients who don't have access to early detection and treatment. This normally presents in the 3rd to 7th decade of life, i.e. people in their 20s, so to their 60s or 70s, when it presents. It's quite a wide ranging. The older you get, the more likely you are to have a cancer if such a lesion exists in your mouth. However, we are seeing more patients with no risk factors and and younger patients, although they still are very, very much less than older patients with risk factors presently. Okay. These arise from the squamous cells of the mucosa, and when we classify these in terms of the size of the lesion to know how to treat these best, and there are guidelines present to do that, we do what we call the tumor metastases and TNM, tumor node metastases staging, 1 being the smallest and 4 being the largest. Okay, and this staging is based on clinical examination, histopathology from surgery, and imaging. Okay, so you will get a staging from the biopsy before the cancer is treated, but that might be the final staging is after the surgical excision of the lesion. This is managed most likely with surgery. In some cases where the surgery margin is quite close or there's known metastases, adjunctive radiotherapy and chemotherapy is given in second care. All these patients will have higher risk for getting further cancers or recurrences of the same cancer, so they need to be monitored long term. Other cancers that you will get in the head and neck include salivary gland cancers as the next most common, and about 0.5 to 0.6 people in 100,000 population will have one of these cancers per year. The 5-year survival rate is better, 72% in developed countries, and management is normally with surgery and radiotherapy. Adjunctive chemotherapy is very rarely used and mainly in research settings at present. There's many different types of these, including mucoepidermoid carcinoma, adenoid cystic carcinoma, pleomorphic adenocarcinoma, but all of these are very, very rare, accounting for about 2% of any oral or head and neck cancer that might present. Then oral melanoma. So this can be either metastatic from the skin, so you will want to look for any of the odd moles if you do find a pigmented lesion in the mouth. This is about 1% of oral cancer. It's definitely detected late because the recognition of mucosal either in the eye or in the mouth is very, very poor for mucosal melanoma. So but it's a very aggressive cancer, and approximately 5-year survival is only 20%. So these are patients in their 30s to their 60s in general when the onset of this occurs. And these patients will need radical surgery and adjunctive immunotherapy and chemotherapy for this to give them a chance of survival. Other rare cancers further than that are lymphomas of the mouth, sarcomas of the mouth, and metastases or hematological malignancies that present in the mouth. So if you look at these photos, the first on your left, moving to your right is lymphoma, then malignant melanoma, and the third is metastases on the lower left. And this is multiple myeloma that is presenting in the mouth as part of a hematological malignancy in the lower right. Don't forget in your examination that skin cancers will occur also, so to keep an eye out for odd ulceration or pigmentation of the head and neck region. The most common being basal cell carcinoma, which is slow, indolent growth and is treated with surgery. Squamous cell carcinoma is much more aggressive in the skin and needs to be treated as soon as possible. There's also lentigo maligna, which is very benign looking to see, and it's not raised, but it tends to be where moles seem to be spreading from a central mole, and you should refer those to dermatology to have a look at. And obviously cutaneous melanoma, which has a better survival rate than oral melanoma. So if we're seeing these lesions and we recognize that there are higher risk lesions in a patient that we've come across, how do you as primary care physicians go about managing this? So there are lots of guidelines out there that you should have access to if you have access to the internet. The World Dental Federation has a fact sheet on this, and in particular oral potentially malignant disorders that we went through. There's consensus guidelines on the management of oral potentially malignant disorders as published in JOMOS, and there's other guidelines. So in the UK, we have the National Institute for Health and Care Excellence, which provides guidelines for our head and neck, for any systemic disorder that we treat within the UK. And they've also got an excellent set of guidelines on suspected cancer. And in that, they have specific guidelines for head and neck cancer. So there's lots of places to get this information from. The gist of it is, however, prevention is better than cure. Early detection gives the patient the best outcome and the most minimally invasive treatment long term. So this is something that you guys can do in the primary care sector. We need to educate our patients and reduce the risk factor exposure that they have to limit the risk of developing potentially oral cancerous lesions and oral cancer itself. As I said previously, in Afghanistan, I know that chewing tobacco in the form of niswar is a big problem, and smoking, and any type of tobacco contact with either cigarette, cigar, hookahs or shisha use will increase that risk. So there's no form of tobacco you can use that will not increase your risk of cancer. So the guidelines within the UK is 14 units of alcohol consumption per week, but for the mouth specifically, the more hits of alcohol there is, the more exposure you have, the least alcohol-free time between those exposures, the more likely you are to develop an oral cancer, because the mucosa and the immune system don't have time to recover from the impact of the alcohol. The aim is to reduce such practices, but ideally the risk in those patients does not go until they stop that habit completely, okay? If someone's been exposed to HPV, for example, then that risk is 16, for example, then that risk is there. It's interesting to know if vaccination programs that we have in certainly Europe and the USA will reduce the risk of those types of cancers occurring in the mouth, as well as cervical cancer in the future. Okay. We need to teach our patients and the communities on how to, as well as how to reduce those risks, or for those with who have the risk factors and can't reduce or stop, to self-screen for any lesion. So we need to tell them that any white patch, any red patch, any ulceration that has been there for at least 2 weeks needs to be seen by a clinician to know whether they need any further intervention or what the cause of that might be. If they've had previous malignancy, those patients should be referred if there's any new lesion within their mouth, but they definitely should be checking on at least a monthly basis for any changes within their mouth, okay? Screening programs in communities, if possible, would really improve this, and this can be done by locally set up measures or by public health foundations if these are set up within the area. The higher risk lesions should have more frequent reviews. So if you know that someone has higher risk for oral cancer, they need to be reviewed on a regular basis, so that if they cannot, for any reason, self-screen, because 90% of the presenting cancers, especially early cancers, will not have any symptoms related to them. we need to be screening for our population. If you are in doubt of whether a lesion is high risk or low risk, do not be afraid to refer or to get advice. And there's lots of ways that, inshallah, you can get that support to be able to judge the risk of a lesion or a patient. Saying that, the need for prevention and early detection and referral to specialist service is very great, especially within Afghanistan. At present, I'm being told by specialists that no reconstructive surgery is occurring in Afghanistan, and only small cancers that have the chance of being closed primarily within the mouth are being treated within Afghanistan. Where the patients have the opportunity to travel to Pakistan and other countries for management, anything above, say, a tumor stage T, N0, M0 cases can be treated within the country. So the earlier they're referred, the earlier these cancers are detected, the more likely they are to have treatment. You want to catch these patients before they become cancers, so that we can treat them and review them often to prevent any problems from happening. Okay, so how are we going to do that? So first of all, we need to diagnose what the lesion is that is being presented. Okay, so there's two ways of doing that in your mind. When you have done your history and your examination, all of those clinical clues will set up for you for what could be the cause of this. When you're looking at these clues, you can use two main approaches to know what your differential diagnosis, i.e. the 2 to 3 possibilities of what this could be, i.e. a benign lesion, a potentially malignant lesion, or a cancer itself. Okay, so these are the things we're looking at in this context. So you can use your anatomical approach to look at a lesion and say, which part of the anatomy has this likely come from? So is it a blood vessel? Is it the mucosa? Is it a salivary gland? If it is, are these more likely to have cancers in them or less likely to have cancers in them? With mucosa sources being much more likely to have cancers, okay? Or lymph nodes, for example. The other way is if it's a large diffuse lesion, or if there's many lesions, you need to think about the different types of pathology that can occur. Is it traumatic? Is it inflammatory? Is it a tumor neoplastic process or a malignant process? Is it an infection? And think about all the clinical clues you've taken from your history and examination that point to one or other. So if you can come up with 3 possibilities normally, or the most minimum likelihood of what these could be, then you need to think about what investigations you can do to then come up with your definitive diagnosis. Okay, so for oral potentially malignant disorders and lesions, unfortunately, the only way to get that definitive diagnosis, and the gold standard at present, is to have a tissue biopsy. Okay, so this is not normally something that can be done in general dental services, so they will need referral to specialist service to do this. So they need someone who knows how to take the biopsy, whether an incisional or excisional biopsy is needed, whether the patient is medically safe to have any surgery to be able to do this. They need a specialist surgeon who can not only carry out the investigation of the biopsy, but also the surgery to treat the lesion itself. They need a laboratory and specialist staff to process the tissue itself. and you need a specialist head and neck pathologist to interpret the results. Is this a normal or abnormal? And if it is abnormal, is this high risk, i.e. a precancerous lesion, or actually is this a cancer? You then need a specialist clinician to agree clinically that this fits with the pathologist's interpretation. And if both agree, then we need someone to be able to come up with a treatment plan and to put that treatment plan in place to manage the lesion. Yeah. So this might be a specialist head and neck cancer physician who has had the experience and has the facilities to then put that management plan into place, which is best and ideal holistic care for that patient. And you also need someone who will be able to monitor that lesion if you're not treating it, or once you've treated it, to note that whether this is returning or a new lesion is occurring in that patient. So this is all that happens in the secondary and tertiary care services in hospital. When you got that diagnosis, when we stage something for being either a cancer or a non-cancer, and if it's a non-cancer, whether it's higher risk for becoming a cancer or not. So when you've done your biopsy, if you can't tell always whether something is going to be a higher risk or lower risk for this. Only the biopsy can tell you. And we call this dysplasia. And there's two major classifications for this. So either the WHO system, which is used most widely around the world, which is mild, moderate, and severe dysplasia, depending on how many cellular characteristics and tissue structural changes in the mucosa, for example, for squamous cell carcinoma, or in the salivary gland for salivary oral cancers, to see if this is a higher risk for cancer. Or there's the binary system, which is more recent in some places used, which is just high risk or low risk. Okay. So high risk lesions tend to get surgery. Low risk regions can be monitored depending on what the patient wants. Okay. So in terms of our management options, there's always something you can do nothing, and that can be either the patient's choice, or if it's a non-cancer, non-dysplastic, potentially malignant disease, that they may not need any treatment. However, if it comes back dysplastic or with something like lichen planus or dyskeratosis congenita or proliferative leukoplakia, then you can either monitor this whilst optimizing any risk factors for cancers they have, or for example, if they're undernourished or malnourished, then correcting that seems to reduce the risk of this becoming a problem in the future. Or you can use surgery to excise the lesion, and that can be with a knife or with, for example, a laser. If it's a large lesion or a cancer, as well as this, to keep the functioning of the patient forward, they will need some reconstruction, rehabilitation to bring function back to as close to normal as possible. They will need management of any complications from any of those processes which occur, and they will need monitoring for long term. Okay. They may, if there's metastases or a high risk of metastasis or spread of the cancer, need adjunctive chemo, radio, and immunotherapies. Although immunotherapies for head and neck cancers is very rare at present. Okay. So when you're looking at oral potentially malignant disorders or diseases, conditions, there is a lot of research in this area to help diagnose things earlier, because it's so important to get treatment early in these conditions. Lots of research have been done to help the clinical examinations, such as Veloscopes, which aim to highlight the amount of dysplasia in the cells that you're looking at when you look at a white patch, for example. And you can see this in the picture on the right. However, they do tend to overestimate the amount of dysplasia that might be in a lesion, because if it's an inflammatory lesion, those cells might also be higher risk. So some people use this to help choose where to do the biopsy from. However, it's not used in general practice at present. Further research is also going into things such as some genetic screening. So if you've got genes that we know are higher risk for, such as the FOXM1 gene, that are a higher risk of you getting oral cancer, you can have genetic testing for this, although this is expensive, and it will say that you're higher risk, but it won't say for definitive sure that whether you've got a cancer at that time, or whether you will definitely get a cancer in your lifetime even, because you may not have any risk factors for this to trigger in the environment. We know that patients with disorders will release little bits of DNA into their bloodstream, and these little bits of DNA are called QMIDs, and you can get that in, say, a 20 ml volume of blood. This is how, for example, pregnancy screening occurs for genetic conditions in the fetus. The same process can be used to look at those cells that have the DNA that has the mutations that dysplasia, for example, is happening. And there's a lot of research into this area in specific other biomarkers, such as cells that are releasing proteins, various proteins, into the blood when they're distressed during a malignant process, or a potentially malignant process occurring, or inflammation occurring. Lots of these are being looked at, but nothing has been shown to be better than early biopsy for a concerning looking lesion. Okay, and even with biopsy, if we've got someone with a high risk lesion, we still can't tell whether that's going to be turning into when that's going to be turning into a cancer. So it could be tomorrow, it could be 10 years, or never, even if you've got a severely dysplastic lesion. Okay, there's lots of research going into technology to help early technicians. So for skin cancers, dermatoscopes are very useful. Cameras to enhance imaging, so to see if there's any things like new blood vessels forming that may be concerning. This is very helpful for that. And also we're looking at artificial intelligence platform to put all the information for us. But at the moment, our own intelligence is much better than the artificial intelligence that's out there, particularly for head and neck cancer. There's also lots of research, such as into immunotherapy and hormonal adjunctive therapies, as well as surgery for treating head and neck cancers. But as such, so far, we haven't made a big dent into the 5-year survival for people with, for example, squamous cell carcinoma is the most common cancer. So this is all in terms of best practice, what we can do. However, sometimes there's hurdles to fit best practice for various challenges. And I've been talking to a lot of clinicians in secondary and tertiary care within the hospitals in Afghanistan to get a better picture of this. And they have suggested things that are barriers to providing best practice, which include little knowledge of oral cancer and the risk factors for this within the population and communities. There's problems with reduced access to primary care. Lots of patients cannot get in to see a dentist who would be able to pick up these problems, even if they've noticed the problem themselves. There are no set referral pathways to specialist care from primary care. If you know, you know. If you don't know, you may not know who or where to get help from if you're concerned about a patient in the general practice. And in terms of the number and level of support in the secondary and tertiary care department, I only know of, well, one oral medicine department in the country, which is at Kabul University, and I think they have 2 clinicians. And there are more oral and maxillofacial surgeons, but however, still only in the major cities that I know of. There's limited access to imaging equipment, and lots of competition for access to that imaging equipment from all healthcare professionals and patients. And most of the resources are all located as close to the capital as possible, which is more difficult if you live outside of there as a patient. All cancers requiring reconstruction, so that's tumor size 3 and above, will need to be referred outside of the country. Majority at the present are going to Pakistan because there is limited experience of the head and neck surgeons in the country currently and there's limited resources in terms of theatre support and reconstructive tools you need to perform these surgeries within the country at present, which is a very, very limited factor, especially if the patient cannot travel, and also funding for that treatment as well. There's very little access to chemotherapy and absolutely no radiotherapy for any cancer available within Afghanistan, I'm told. So anyone who needs any adjunctive therapy for their cancers, they're not going to get it in Afghanistan currently, is my understanding. And if you've anything different that you've heard, please do let me know, but this is from the specialists that I've talked to in Afghanistan. So what can we do about the situation? So all the problems we've discussed earlier, we need to address. So we need to be able to network and collaborate with clinicians, politicians, charities to gain the resources and to set up pathways via local governments and external services to gain education for patients and the population at large, to become aware of oral and head and neck cancer and what to look out for so they can self-screen and attend primary care physicians and dentists as need be. We need to generate resources to be able to do this and to deliver the care we need. We need to increase the number of general dentists in Afghanistan and doctors and increase their knowledge, as we're doing today, about how to pick up high-risk lesions of the head and neck region. We need to increase the number of secondary care and tertiary care specialists such as oral medicine, oral surgery, oral and maxillofacial surgery surgeons and departments, and the resources and support staff they need to be able to do their jobs. We also need to address training. So we need to gain the experience for those head and neck cancers who are surgeons who are in the country so that they can start delivering further higher level care surgery so that we can treat all the cancers within the country, ideally ourselves, without the patient needing to travel. And we need to bring those resources ideally in an equally accessible way to the whole country. So do we send specialists to work in other countries at the moment? Do we raise money to gain the technology to do this at the moment? We don't know what is the greatest need, but a plan needs to be in place so that this can be set up. What we really need, however, and this is where you can come in, is to set up referral pathways between the patients, primary care general dentists and doctors, and the specialist services so that patients with these high-risk lesions can access care as early as possible. You're the experts of what the needs are in your region, so please talk to each other and see if we can work with charities and with the local infrastructure to try and build these referral pathways up. It's in your hands. When we look to the future, this is your turn to make it happen. In the interim, remember to assess risk assess for oral cancer with every patient that walks through your clinic door. Do your extraoral examination, including lymph node and intraoral soft tissue examination on every patient you see. Be aware, and if there's any concern, refer as early as possible to specialist services, and review and monitor patients with lesions to see if they change. You can use photos to help review lesions and see if you think they've changed. Patients have mobile phones with cameras on them. Make use of that if you can to keep records up to date. And please educate patients and your local communities about self-screening and risk factor modification. We're here to help. We have Dean Support Hub for advice on complex cases are here, and we're very happy to provide whatever support we can in the interim and try and improve healthcare provision worldwide where possible. So that's the end of my lecture, and I want to thank you for listening. If you've got any questions, you can place them in the chat now, or you can email me at a later date, zsaid@nhs.net. Feedback is welcome. I'm happy to provide other lectures, for example, history and examination techniques, or anything more specific. I'm happy to take requests for that and plan for that in the future. If you are looking for places to refer at present, if I go back to my acknowledgements, I'll leave that on the screen for you to take pictures, but there's an email address and a postal address for written referrals at the teaching hospital in Jamamena, Kabul, for the oral medicine department, and they're happy to take referrals by email, or most referrals come in by direct phone to the general dental hospital that get referred on to them also. So if you phone the main hospital, they can take that for you. Okay. Okay. So if there's any questions, I'm just going to have a look in the Q&A and chat and see if there's anything there. Let me look in the Q&A. There's a question in the chat about whether if the dentist can take a biopsy, can they take the slides and report to Dean for diagnosis? So in terms of the photos of the lesion, yes, we were happy to look and see if something needs a biopsy. At the moment, we haven't set up for services, because many of the pathologists are very busy, to whether they can do reports on slides or photos for this. We need labs really in Afghanistan to process this ideally, and we're at the present, we haven't set up for dental pathologists to be able to diagnose biopsies slides for this. Also, the slides need to be processed by lab technicians to get the best reports possible. Do we have any specific consideration on pediatric oral cancer? So pediatric oral cancer, thankfully, very, very rare. They should have the same consideration. So the patients with dyskeratosis congenita, oral graft versus host disease will be the children who have these, and children who unfortunately get lichen planus potentially will be the younger patients who get these conditions. But and also other things like the rare, they tend to have the rare rhabdomyosarcomas, etc. And they're treated in the same way as the adults at present. So really, there's no specific considerations. Just to have in your mind, if something looks odd, even if it's a pediatric patient, don't rule out that it's a high risk cancer or a potentially cancerous lesion. So the youngest patient I've diagnosed with oral cancer has been 1 year old. So children do get these cancers. They're thankfully very, very rare. Any other questions? hope that answered your question so far. If there's no other questions for now, if they come later, happy to take them to my email, zsyed@nhs.net, or via the Dean Support Hub infrastructure. Thank you very much for your time.
Perfect. Thank you, everyone. Thank you, Saida. Thank you for everyone for coming, and inshallah, it's of benefit. It's important for us as dentists to educate patients on the risk factors and also know what to look out for and when to refer if possible. As discussed, the management obviously is different in Afghanistan as it is in the UK, but inshallah, we can use what we learned today to try to help our patients. So if that's everything, then I hope the rest of you guys have a good day, and inshallah, take care.
Thank you, Zayan. Thank you, everyone at Dean, and for the audience as well. Alhamdulillah.